Hey guys, good afternoon. Let's enjoy the chest radiographs with Dr. Y. Session 12, Atelectasis. Before starting atelectasis, let's review the session 11, pulmonary hilum. We remember this woman's chest radiograph. She used to be healthy last year. Please look slowly and carefully her healthy, normal-looking right hilum. This is her today's film. What's the difference? Slowly find out and describe yourself. What's different from last year's normal radiograph and today's abnormal radiograph of right hilum? Slowly describe, please. What do you find? What do we see? Right hilum is enlarged, with increased opacity, with irregular margin, and obscuration of normal pulmonary artery and vein, and compressed, indistinct airway, and plus a daughter nodule and right paratracheal lymphadenopathy. How do you feel now? Feel more comfortable than before about the hilar pathology? Let's begin our new session. Session 12, atelectasis, collapse. A. Pathophysiology. Atelectasis is reduced inflation of all or part of the lung. One of the commonest mechanisms is resorption of air distal to obstruction, e.g. neoplasm. B. Radiographs and CAT scan. Reduced volume is seen, accompanied by increased opacity or attenuation, radiograph or CAT scan, in the affected part of the lung. Atelectasis is often associated with displacement of fissures, bronchi, vessels, diaphragm, heart, or mediastinum. The distribution can be lobar, segmental, or subsegmental. Fleischner Society. Causes of atelectasis. Obstruction of a lower bronchus where the collapse may occur in many dissimilar conditions. First, intrinsic mass, such as lung cancer. This is most important. Second, intrinsic stenosis, such as tuberculosis. Third, extrinsic pressure, such as lymph node enlargement or mediastinal tumor. 4. Bronchial plugging, such as foreign body or mucus. Chest röntgenology, Benjamin Felsen. Changes in atelectatic lung. Volume loss leads to anatomic alterations within the atelectatic lobe, as well as compensatory changes in adjacent structures as they attempt to occupy the space left by the atelectatic lobe. K.S. Lee. Radiographic findings of atelectasis. Please remember these signs when you see the films. 1. Direct signs. 1. Increased density. 2. Displacement of fissures. 3. Crowding of pulmonary vessels. Indirect signs. 1. Hilar displacement towards the lesion. 2. Elevation of hemidiaphragm. 3. Crowding of the ribs. 4. Shift of mediastinum towards the lesion. 5. Compensatory hyperinflation. We already have learned many things about chest radiographs. First, lobar anatomy in session 2 and silhouette sign in session 6. And we also learned lobar anatomy in pulmonary lobar pneumonia in session 11. So this will be easy, not difficult for you and me. Let's just begin. This is the first case of right upper lobe lesion, right upper lobe collapse. What do you see? Right hilum is unclear and elevated. Right upper lobe shows haziness, consolidation or collapse. Yes, minor fissure is elevated. Trachea, mediastinum is shifted to the right side. And also the mid and lower lobe is hyperinflated. Okay, that's simply right upper lobe collapse. This is contrast-enhanced axial CT. Proximal bulging, convex contour of mass, necrotic mass. Distal concave collapse of right upper lobe, probably squamous cell carcinoma of right upper lobe. Dr. Golden named this sign as Golden's S sign or inverted S sign. Another patient of right upper lobe collapse, but the cause is different from the previous one. Increased opacity here. Collapsed right upper lobe, internal tubular bronchiectatic lung. Hilum is elevated. This should be minor fissure. Hyperinflated right middle lobe and right lower lobe. So this is right upper lobe collapse due to chronic endobronchial tuberculosis. This time should be right middle lobe collapse. What do we see? Look at the clear left heart border, but right heart border is not clear, with a somewhat increased opacity here, and not clear right hilar border, not clear descending pulmonary artery margin, and minor fissure is not visualized. But the other lung, right side lung field looks normal, not hyperinflated. This is right middle lobe collapse. Look at this lateral film. We see clear triangular wedge-shaped, sharp-margined major fissure, sharp-margined minor fissure, homogeneous increased opacity of right middle lobe collapse. In lateral film, it is very, very clear to define as right middle lobe collapse, but in frontal projection, it is not so easy. This is another case of right middle lobe collapse. How do you feel? Right heart border. Clear? Not clear. Yes, not clear. Somewhat ill-defined increased opacity. Hilum looks okay, but minor fissure is not visualized. The other lung field looks okay. Look at this lateral film. We see triangular increased opacity here, but not so much clear than the previous image. Actually, this is the usual feature of right middle lobe collapse we commonly see on the reading room. This is more usual face of the right middle lobe collapse. This axial CT shows small triangular right middle lobe collapse attached to right heart border. This is right upper lobe. This is right lower lobe. Right middle lobe takes only 10% of the whole lung zone, so the other lobes take no hyperinflation when right middle lobe is collapsed. Then this must be right lower lobe collapse. What do we see? Increased opacity here, behind the right heart, and clear right heart border. Indistinct, small right hilum probably shifted here, and hyperinflation here. So this is right lower lobe collapse. Right lower lobe collapse in lateral image is not so impressive, just somewhat increased opacity here. Not special, nothing attractive. How about this axial CT of right lower lobe collapse? This is from bronchiectasis, collapsed right lower lobe. This is another case of right lower lobe collapse. Small, elongated shape of triangular right lower lobe collapse here. Dense collapse with internal calcifications here. Clear right heart border and somewhat hyperinflated right lung and small right hilum shifted here, and several small peckers of calcifications telling us I am tuberculosis, right? On this CAT scan, we see collapsed lung, right lower lobe with internal calcification. This is right lower lobe collapse. Don't you feel some déjà vu from the left upper lobe pneumonia? Yes. Left upper lobe increased opacity, hilum is increased, hilum margin is obscured, density is increased, upward deviation, and Luftdicke sign here around aortic knob. Aorta line is okay, paraspinal line is okay, left hemidiaphragm is okay, mid and lower lung zone show hyperinflation. Yes, correct. Left upper lobe collapse, atelectasis. And there is something more here. In distal left main bronchus, there is something blocking here. Yes, left upper lobe lung cancer. What do we see with this lateral film? This is major fissure of left side, shifted toward the upward and anterior side. And this is upper lobe, collapsed upper lobe. And this bigger triangle is hyperinflated left lower lobe. Yes, left upper lobe collapse. Axial contrast enhanced CT, fused axial transverse PET-CT. Left main bronchus, intraluminal, highly enhancing lung cancer, squamous cell type. And this is inverted as, oh no, actually not inverted, normal S sign. Proximal bulging mass, distal concave lung collapse, left upper lobe collapse. Dr. Golden's sign. And look at this PET-CT, heart uptake here. This is all lung cancer. Then you are the last one, left lower lobe atelectasis. Sure, right. Very characteristic, triangular shape, increased homogeneously, increased opacity here. Aorta line is obscured. Paraspinal line is obscured. That means this is posterior location. This is normal heart border. We see something more here. Round. Yes. Proximal mass. This is the lateral film of left lower lobe collapse. What do we see? What do we don't see? Only one hemidiaphragm. This is normal right side. Left side is obscured from here. And increased triangular opacity about here. Increased white density of left lobe collapse. Another inverted S sign on this axial CT. Convex proximal, concave distal. Convex proximal is well-enhanced mass such as carcinoid and distal collapsed left lower lobe. This must be that mass on the CT. Yes, left lower lobe collapse. Very characteristic findings. What do we see? Very easy, very easy. Total haziness, total whiteness on the right side. No hilum visible, no right heart border visible, no diaphragm visible. Decreased inter-rib distance. Mediastinal structure is shifted to the right, trachea is to the right, left lung is hyperinflated, and we don't see the right main bronchus. That may be from tumor up to carina level. Right total collapse. This lateral film is interesting. Total haziness, except anterior side. This may be due to the herniation of the left lung to the right side. And only one hemidiaphragm visible. Right one is gone. No hilar structure, no pulmonary vessel. Yes, this is a right lung total collapse. Coronal contrast enhanced CT. Right lung mass, lung cancer up to the carina level. So this is matched for this chest radiograph. And the other areas all lung collapse. Mediastinal shifting to the ipsilateral, diaphragm shifting to the upward. Right side chest cage is smaller than left side. Left lung is hyperinflated. Total lung collapse of right side due to lung cancer in right main bronchus. We don't need any more explanation for this left side total collapse because we have experienced just before total right lung collapse. Just difference is this is left main bronchus and tumor is occluding here. Left main bronchus lung cancer from here to somewhere here and total left lung collapse. This is very interesting, very characteristic, one of the famous combined collapse findings. Right middle lobe and right lower lobe collapse due to obstruction at the bronchus intermedius level. Actually, this is minor fissure and right middle lobe collapse, and this is major fissure of right lower lobe collapse. Right hilum is small and unclear, and the other lung, only lung, right upper lobe is very hyperinflated. This is obstruction at the level of bronchus intermedius, combined collapse. Coronal contrast enhanced CT. This is bronchus intermedius, tumor obstructing here, and the middle of the bronchus intermedius. Middle lobe collapse, minor fissure, lower lobe collapse. This will be major fissure. Please match with chest radiograph. Combined collapse at bronchus intermedius lever. This is the last slide of collapse atelectasis. Does this look very interesting? Very attractive? What's wrong with this one? Okay, first we know this. Yes, left lower collapse. What do we see here? Before going to right side, we have to admit that left hilum is inferiorly more displaced because left lower collapse is here. So this hilar level cannot be the standard over lower left hilar level. Okay, on the right side, we have just finished right combined collapse. This is minor fissure, major fissure, middle of collapse, lower collapse, and distinct hilum and hyperinflated right lung, and also hyperinflated left upper lobe. Yes, triple collapse. This actual CAT scan gives us the answer. Left lower lobe collapse, inflated left upper lobe, right middle lobe collapse, obliteration of right heart border, then this must be right upper lobe, and this is right lower lobe. This is superior segment, right lower lobe collapse except superior segment. Middle lobe, right lower lobe, left lower lobe collapse. Interesting. Now we became the master of the lung collapse, lobar collapse, atelectasis. Okay, very good. Let's move on. Answer for the quiz. What's wrong with this healthy baby? The answer is nothing wrong. He's healthy. What we see on the right upper lobe side is normal enlarged thymus. We used to say this as name of sale sign. And this is not upper lobe pneumonia or upper lobe collapse. This is normal thymus. Are you correct? This is the image for next session quiz. What do we see? Somewhat bizarre shaped densities here and there, almost everywhere. What is this? Thank you very much. See you next time. Bye-bye. Like, subscribe will be a big support to me. Thank you very much and good luck. See you next time.